Okay, great.
So thank you everybody for connecting, and Rob, thank you for making this happen. This meeting is an important meeting, and to the last meeting of the month, the fellows from Ryder are doing a great job, and you're doing a great job leading the team. Looking forward for a great case today. Okay.
Thank you, sir. Okay, with that, I'll get started. My name is Roberto Cortez, one of the second-year trauma fellows at Ryder. It's an absolute pleasure to be able to present at this conference. As Dr. Martos said, it's really an outstanding opportunity for us, particularly as the fellows, to hear a wide variety of trauma strategies and decision making. It really is a priceless conference for us. So I appreciate everybody joining, and I hope that we have a nice, fruitful discussion from this case. So I titled this case Bones and Bowel. This is a trauma consult that I had last month at Jackson South, and I titled it Managing Polytrauma in the Setting of Gross Contamination. And with that, we'll get started. I have no disclosures. So the trauma alert came in, 30-year-old male, multiple abdominal gunshot wounds. That was all the information that we received on the page. And when the patient arrived, I'll go through his primary survey. His airway was intact. He had equal bilateral breath sounds. He was tachycardic to 126. His blood pressure was 104/85. He had bleeding from a right buttock ballistic wound, palpable distal pulses throughout. We secured peripheral IV access. He was moving all four extremities. And upon fully exposing the patient and turning him, we noted 4 ballistic injuries. There was 1 in the right lower quadrant with evisceration of small bowel. There was 1 to the right hip, and there was 2 in the right buttock. Go through his quick X-rays that were performed at the bedside here, and then down here. I'll give everyone a chance to take a look. So with this information, we'll go ahead and take a brief pause for our first discussion in terms of where we stand with the patient now and kind of where our thoughts are and what our plans are going to be in terms of the next steps. And I'll start with Dr. Untract.
Yes. So how long from the trauma did you get to see him? Did you get those observations?
This was directly from the scene, probably. You mean in terms of when he sustained the gunshot wounds?
Yes, yes.
Yes, directly from the scene, I would say less than maybe half an hour, 20 to 30 minutes.
Okay, very good. So multiple gunshot wounds, and you can see the fractures of the, looks like intertrochanteric fracture on the right, and fracture of the iliac crest, and evisceration. So, and that's in a setting of tachycardia and a blood pressure that's trending a little too low, still over 100, but he has the potential to go into shock. So at this stage, you have the IVs in. I'd put a Foley catheter in. Look at the abdomen for signs of bleeding with ultrasound, and plan to give him he needs antibiotics, and plan to get him to the operating room.
Thank you, sir. Great points. Dr. O'Connell, any comments?
It looks like this gentleman is in compensated shock. If anybody's interested in the military experiences that we start seeing morbidity and mortality in kind of the 110s is kind of our cutoff, much higher than some people would accept as a blood pressure. So I would say this guy is definitely in some kind of hemorrhagic shock and needs to be treated aggressively. The fact that he has the evisceration kind of takes the diagnostic dilemma out of it. So he's going to need to go to the OR because he clearly has an abdominal wound. So that makes I think the algorithm easier at least for me. If this was a blunt injury or, there was no obvious signs of abdominal component, I would say we would do what in the old days we used to call a triple contrast, but now just a double contrast, which is IV and rectal contrast to see if you have an injury to the rectum or the large intestine. And I have to agree with the Dr. Utrecht's assessment. Antibiotics definitely for this guy, but I would probably call for massive transfusion and start resuscitating him, give him antibiotics, and take him to the operating room for exploratory laparotomy. And I would probably at the same time I would call either for a rigid sigmoidoscope or a flexible sigmoidoscope in the OR, as well as doing a rectal exam on him. That's it.
Yeah, wonderful points. Thank you very much, sir. Dr. Kasim, any comments?
I agree with Dr. Utrecht. I don't think that I would do any contrast studies in a patient like this. He's well compensated, is in hemorrhagic shock, and looking at the pelvic X-ray, it scares me a little. The only thing that I would add to the management would be, I would at least put an attempt to put an introducer into the left femoral in case I need to deploy a Reboa in the operating room for hemorrhagic shock control later on that I would anticipate. I think I would take him straight to the operating room, and the only other thing would be, would I do a single contrast study to make sure he's got 2 kidneys? I'm not sure either. I think he belongs in the operating room with an appropriate left femoral introducer and massive transfusion protocol initiated, at least, and take him quickly to the operating room, because I think he's going to crash.
Yes, sir. Thank you. Excellent points. There's a question in the chat about peripheral pulses being present. Dr. Neiman, thank you for your question. Yes, we did palpate distal pulses in all 4 extremities while he was in the resus bay. So thanks everyone for your comments. I see Dr. Varon on the call as well. Thank you for joining, sir. You know, we have the absolute pleasure of a world-class anesthesia team and resuscitative efforts in conjunction with our operative work. Any comments, Dr. Varon, about your strategies for preparing your team in the OR?
As you know, when you have penetrating trauma, the most important prognostic indicator of outcome is time to OR and stop the bleed. So basically, most of the interventions by this point should be done in the OR. I still request, you know, just a type and cross. That one you need to get, basically, and a hospital number. And then the patient should go to the operating room for the rest.
Just a really quick comment. Dr. Kasim, you know, when you have these injuries that are hypotensive, there might be a question of infra, you know, like an iliac vein injury. You know, just be cognizant putting a femoral line will only exacerbate the bleeding. So I probably would try to stay above the diaphragm if you're thinking about a line for resuscitation. And actually just wouldn't work.
Great points. Thank you, Dr. Ginsberg. Thanks for all your comments so far. That's wonderful. We'll go on to the next slide here. So we went for our discussion points here. Just to round out our secondary survey, it was following commands. Noted the 4 apertures, 1 in the right lower quadrant with evisceration, right thigh ×1, and then right buttock ×2. Palpable distal pulses moving all 4 with a base deficit of -4 and a hematocrit of 45, and a type and cross was sent, as you mentioned, Dr. Varon, before going back. So we went to the OR emergently, and our findings, we found hemoperitoneum. We packed all 4 quadrants, and then we were able to note several ballistic injuries to both the small and the large bowel. There was a through and through ballistic injury to the small bowel. I'll get into the measurements from Trites, rough measurements, of course, and then an additional mid-jejunal small bowel injury, as well as a ballistic injury through the cecum and the terminal ileum with succus and stool spillage. There was a significant degree of maceration and kind of shredding of the right psoas with a big blown out, as you saw on the x-ray, iliac crest that was essentially visible from our laparotomy on the inside. And I do have an image here, not the best quality, I apologize, but this was really the focus of the entry point for the gunshot, where the psoas was pretty much just obliterated here with full communication to the iliac crest, and then below the inguinal ligament to the femoral space as well. So just to round back our injuries, 2 small bowel injuries, actually 3, 2 small bowel, 1 terminal ileum, the cecum, and this traumatic hernia in the right lower quadrant where the patient had eviscerated previously. And that's a little closer view here with what we saw in the OR. So we'll take another brief pause to talk about our intraoperative strategy and how we proceed given these findings in the OR. And I'll start with you, Dr. Untracht.
Well, okay, the picture you showed, everything looks pretty clean in the abdomen. I guess you removed all the hemoperitoneum, but it doesn't look like a lot of stool soilage, or you just cleaned it up very well. So that the procedure is, in this case, if his hemodynamics are stable, he's producing urine, his tachycardia is resolving, and there's no active bleeding, I would deal with the visceral injuries first. And I can't really see this. I see the cecum, but I can't really see the injury, the size of the injury, and the injury in the adjacent ileum. But the options are in this case, it'd be a reasonable option, given the way it looks, without a lot of soilage, to do a primary repair, or repair and exteriorize those 2 injuries, or do a local resection of the terminal ileum and the cecum and proximal ascending colon, and either exteriorize those 2 together, or do a primary anastomosis, which would be, depending on the overall picture, would be something acceptable in this case if he wasn't hypotensive and he was a rapid responder to the initial resuscitation. That would be something to consider. And then for the small bowel, I haven't seen those either, but depending on how they look, I would either repair those primarily or do a local resection. If he becomes unstable, then you just have to limit the soilage, either just staple across them and leave them not in continuity, stop any major ongoing bleeding, and then get him to the ICU. But doesn't look like that's the case here.
And just for some more information, Dr. Untracht, thank you for your comments. He was being actively transfused, and we did get a repeat resus intra-op that showed that the base deficit had worsened to -8 from -4, and he was getting more hypotensive throughout the case, just to clarify some of the...
Right. Yes, then I would do the latter. I would just try to limit the damage as quickly as you could, and look for other signs of bleeding, and get him out of the operating room as quickly as you could. Really clean out all the contamination, look for the signs of the open fracture in the iliac crest, irrigate those out, and not keep him too long in the operating room.
Yes, sir. Great comments. Thank you very much. Dr. O'Connell, any comments?
I generally agree with Dr. Utrecht. Thinking it seems pretty straightforward, the pattern of injuries that you mentioned. Something tells me that there's more to it because we're all here for these complex cases. But I think thinking of the pitfalls for this case, number one is, should you re-anastomose in this patient? And it sounds like with the additional information you just provided that this patient should have like a staged damage control surgery. I would probably just resect the areas that were injured. The other pitfall that I could think of is what to do with his ileal and cecal injuries. Now you could do an ileocecectomy, but sometimes there are problems when you go to re-anastomose. So a lot of people would do a right hemi along with the ileectomy. So that's another area for a pitfall. And then I would just either interrogate or how do I put it, convince myself there's no missed injuries. And the missed injuries I could see here are an extraperitoneal bladder injury, which you could pretty much rule out just by putting a Foley. And then again, with these thigh injuries that go into the abdomen, I feel it's important to rule out a rectal injury because that may not be visible and can be morbid. So again, either convince yourself of the trajectory of the ballistics or actually visualize the mucosa of the rectum to rule out an injury. That's all I have.
Thank you, Dr. O'Connell. Great comments. Dr. Kasim?
Well, the first thing that I would do is what Dr. Vernon told us, stop the bleed. So there is a big hole on the right lower quadrant, hack that. That is where most of the bleeding is going to be coming from, in my opinion. And then I would attend to the bowel. And in a case like this, a very quick right hemicolectomy with removal of the offending ileum is what I would do rather quickly, and it doesn't take very long to do that type of operation, which will be a slightly extended right hemicolectomy. And staple the ends, leave them behind, and then check twice before you do one more cutting if there is anything bleeding. Run the ball one more time, make sure that you're not missing anything, and leave the packing inside and come back, take the patient for further resuscitation in ICU. And while he's in ICU, you may want to do a rigid or flexible sigmoidoscopy to make sure there's no rectal injuries. That's what I would do.
Excellent points. Yes, sir. See a couple more on the call here. Dr. Neiman, any comments, Dr. Neiman?
Hi, can you hear me?
Yes, sir.
Yes. So again, I agree. I would first make sure, as you did, that hemorrhage is controlled. Then I'd staple resect the injuries. Since hemodynamically he's not doing better, I would also opt for damage control. I do think that after you staple the injuries, you should explore the retroperitoneum, zone 3 on the right. Make sure there's no iliac injury. If you can identify the ureter, good. If not, this could wait for a second stage. And definitely you should look at the rectum. And with a rigid ricoscopy, I think it should suffice since you do see the sigmoid. But yes, all these, and as soon as possible to the ICU.
Thank you, sir. Thanks, everyone, for the great comments. Move on here. So we did elect to perform in a damage control fashion resection and getting the patient up to the ICU. So we performed 2 small bowel resections of the affected small bowel. We performed an ileocecectomy, and then we closed the traumatic right lower quadrant abdominal wall hernia, the one that was anterior. Some of the measurements here that we roughly approximated in the case, to the first staple line was about 120 centimeters of small bowel, leaving an island in the center, which was 140. And then the final one leading up to our terminal ileum was 130, and the remainder of the colon was unaffected. The majority of the bleeding, as was alluded to in the picture, was really from a iliac crest that was shattered. So we did pack this. performed an extensive washout, a temporary abdominal closure. You can see his resuscitation here below before getting the patient up to the intensive care unit. We did talk about, there was no, it should mention a rectal exam and resus, showed no blood. And we did not perform a rigid proc on this operation. We did on the next one. But now that you're out of the OR, getting the patient, say, up to the ICU, or would there be any role for postoperative imaging? And if so, which one would you elect? I should mention we did identify the right ureter intraoperatively, and there was no injury present. And I think that covers up the rest of the findings on that first operation. So now the patient's out of the OR, planned up to the ICU, and would you perform any imaging at this time? Dr. Untract.
Well, I would ask the orthopedist about the fractures and what images they wanted. And otherwise, right now, there wouldn't be anything acute that I could think that I would be doing based on the images. If the patient has good urine output, it's not bloody, and there's no blood in the rectum, I think and based on the trajectory of the bullet wounds, I wouldn't expect either kidney or the ureters to be involved, and you would have seen that. You would have had some indication of that. Unless the orthopedist wanted certain other images, I don't know that I would pursue any right in the immediate post-op period.
Thank you, Dr. Untract. Dr. O'Connell, any role for any imaging here at all, or what do you think?
The only thing I would think about is like when you have these retroperitoneal injuries, just to make sure that it doesn't affect the spine. Probably low yield if the patient's moving both of their lower extremities is unlikely. But you would probably more just for liability reasons and stuff like that. You might want to make sure that the patient doesn't have an unstable spine fracture. You can't really visualize the spine well during the case. Although I do recall that you had a plain film. That's the only thing I can really think of, but that's kind of more CYA stuff. I don't know if every person would do that. That's all.
Yes, sir. Thank you. Dr. Kasim, any comments?
I think you're fortunate you're able to identify the right ureter, because that would be the major injury that would worry me in a case like this. Having identified it and you are happy that everything looks intact, the possibility of the right kidney being injured is remote in this case. Of course, the bullet could have traversed the spine into the spinal cord, etc. But he's moving both his extremities before you intubated him, and that excludes that. And so, in my opinion, there is no urgent need for any imaging at this moment. I will stop at that. Thank you.
Thank you, Dr. Kasim. Dr. Neiman, any points or comments?
No, unless I can't think of a specific issue to merit any imaging right now.
Thank you. A couple questions in the chat. Dr. Contreras, sorry, how long did the first operation take? I think that one was about an hour to hour and a half in the OR. And then Dr. Untract asks, this is Jackson South on the slide here. This is Miami Beach. Until we open a trauma center on Miami Beach, maybe that'll be the picture we get, but not yet. I'm sure Dr. Ginsburg can talk about that. So we did get some imaging, which I'll go through here, really just abdominal pelvic CT to carry through. And I'll bring up the reason here, which will become a little more clear. It's hard to demonstrate from some of the images that I've shown you. But in the area where the right lower quadrant gunshot wound was with the eviscerated small bowel, it was just above the inguinal ligament tracking down and within a finger breadth were the femoral vessels. And so we did want to make sure that there wasn't a pseudoaneurysm or any occult vascular injury, despite him having a reassuring vascular exam. I do think that this really demonstrates how close these fragments came to. You can see right there at the femoral artery coming down, how incredibly close the trajectory was to becoming an even bigger problem than it already was. And thankfully, there was no vascular injury or pseudoaneurysm that we demonstrated. So our laparotomy is here, but just below my hand here is where the traumatic hernia was, and just kind of interrogating that, it was extremely close to the femoral vessels, which is why we got that imaging, just to exclude that. So we'll go back to the, so now we have 2 small bowel resections and an ileocystectomy in a patient in the intensive care unit. Hemodynamics are improving, progressively weaned off any vasopressors, which were on very briefly, but otherwise resuscitated well and ready for the OR for a take back. And just to review kind of the anatomy at this point, 2 small bowel resections and an ileocystectomy in terms of reconstructive options, and where we go from here in a patient who's otherwise resuscitated, hemodynamically normal, and ready for the next operating room take back. And what are we strategizing here, and what are we going to do when we get him back to the OR? Dr. Untracked.
And you left him he's in discontinuity at this point. Is that right?
Yes, sir.
Okay. And so you're taking him back now with the next day or 2 days later, and he's totally stable, and everything is fine physiologically. Is that right?
Correct.
Yeah. At this stage, I think you could hook him back up, just do the 2 small bowel anastomoses, and you have an ileocystectomy. I think you could either extend that to a right colectomy if there's any concern, or just do a primary anastomosis to the ileum to the ascending colon, either way, and that's it. Close the incision. You've already repaired the hernia, so I think you're good to go.
Thank you, sir.
Definitive second procedure.
Dr. O'Connell?
No variation between Dr. Utrecht's plan and what mine would be. I guess if you want to have ortho come in, if they wanted to breed some of the dead bone fragments, or they love those Vanco beads, if that is an opportunity to do that before he's definitively closed. I don't. That's not my area of expertise, but I would defer to the orthopods on that one.
Thank you, Dr. O'Connell. Dr. Kasim, any comments?
Looking at that reconstruction CT, it scares me what you're showing on the right side, with multiple fractures and the hip joint being involved. And so normally, you would go back to the operating room 48 hours, 72 hours. But I wouldn't be in a rush here. I would definitely have my orthopedic experts look at this case carefully to see what they want to do, so that they can at least do a reasonable reconstruction of the right ilium and also the hip joint area, and then I can concomitantly or separate time perform a right hemicolectomy with re-anastomosis, 1 anastomosis only. I would not do multiple anastomosis unless it is called for, and then try to close the abdomen. And that would be my plan. Again, it's a very scary picture on the right side.
Thank you, Dr. Kasim. Yeah, it was pretty devastating CAT scan. Dr. Neiman, any comments?
I do wonder what's the orthopedic plan for this femur. I don't think that needs to be addressed at the same operation. I think, as everybody mentioned, anastomose the bowel. I don't think there's any anastomose I would say go, because it's those are all relatively long bowel lengths. And I wouldn't address the rectoperitoneal hernia at this time, and probably primarily reconstruct the anterior abdominal wall.
Dr. Ginsburg, are you there?
Yes, I'm here.
Remember, we had a conversation about this case before this next take back. Any comments on your decision-making kind of strategy and some, you know, pluses and minuses of the approach here on this take back in particular that you were
Well,
considering?
basically, when I took this guy, I did the take back. I didn't do the original. There was a large defect. First of all, it was like, you know, the actual swelling in the gut wasn't bad, so I decided just to hook him completely up, and we were able to do that very quickly. But the real question here, and when I was told that this was going to be presented today, I spoke to Bobby, to Dr. Cortez, and I said, you know, one of the things that I want discussed, because I think it'll be a center of discussion, and sometimes with some of my partners it remains controversial, was in the case of the ileocecectomy, when I hooked him up, I thought about putting a drain in the big defect that was in that right lower corner. I mean, there was a big defect, but I don't like putting drains for colonic anastomoses or any small bowel anastomoses, because there's enough literature out there now that claims that leaving drains, at least in colorectal surgery, may actually increase the rate of fistula, you know, of leaks. So in this case, it was a decision that I didn't want to leave a drain right next to that ileocolonic anastomosis, and I felt that whatever collection he would have, and I washed him out real well, that we could always percutaneously drain him. But I'd like to hear what, you know, some of the other people's opinions are, because it did go on to affect the case afterwards. Although I'm not sure anything, even if there was a drain, something, you know, wouldn't have happened. But so you can go around and ask people.
Thank you, Dr. Ginsburg. Yeah, great points. Any commentary from the panelists about drainage in this case?
I wouldn't
Well,
drain.
drains
Joe?
are two-way street. You know, we've been taught drains are two-way street, but closed suction drain is supposed to be superior. It all depends on, you know, what you're looking at. If there's going to be a large collection in a big hole, I think it is wise to put a suction drain in there and then maintain it, observe it carefully, because like we were taught much earlier on, bacteria can go in.
Yeah, and I think in this particular case, like you, oh, go ahead, please.
I would say is completely just dependent on the frame of mind and the gestalt of the moment. If that hole, the tissue edges look necrotic, or they need to be debrided, and there was a lot of contamination and the fluid inside it looked dirty, then it would be totally reasonable. But it's very hard to say, because if you put the drain in and you know, it prevents an infection that occurs later, you'll never know that it prevented it. You might think that you put it in uselessly. So it's I don't think it would probably make or break this patient. And sometimes we just put these drains to treat ourselves. But I would say I wouldn't be for or against it.
Thank you, Dr. O'Connell. Dr. Entrak, you were saying leaning towards no.
Yeah, I wouldn't, in this case, based on the pictures, from what I can see, I wouldn't leave a drain in this case. It's a relatively large space, but it's separate. It's extraperitoneal. And was it open to the outside posteriorly through the skin, or not? It
Yes,
was. So it's a big open to the back. So if it might get to the point where you may need to pack it from posteriorly to let it close from the inside out. But at this point, I wouldn't leave a drain. And if it is open to the back, then it's already, you already have access to the cavity. If you can close the peritoneum over that space, I mean, I would probably try to do that, just to try and encourage the bowel not to fall into the space and develop a hernia. But especially if it's open to the back, I wouldn't leave a drain intra-abdominally. And then I have a question for Dr. Ginsberg. Those studies that I presume that there are more studies that you're quoting about drains. Are they randomized studies? Because in the old days, they were not randomized, and really drains were left in the cases that the surgeons were worried about, and you would expect more leaks in those cases. So are these good randomized studies that really show that the drain is causing an increased incidence of leaks?
Excuse me, I'm sorry, I missed that last. It was a question you had.
If you were quoting the more literature, and I'm not aware of the recent literature, but in the old days, those studies were retrospective, and they weren't randomized. So the issue was, were the surgeons just leaving the drains in the cases they were worried about, and and you would expect those to leak more. So are these randomized studies?
Let me just say, these were the cases that I looked at. I can't remember if they were retrospective or prospective. They might have been prospective, but it wasn't in trauma cases. These were in low anterior resections where you had, colonic anastomoses or descending colon resections where, colorectal guys used to leave a lot of drains, in case they leaked. And then they did a reanalysis and found, that they leaked more with drains than not. And so I tend to now, use drains for pancreatic injuries with anastomoses around them. I don't care because, the pancreas, I'd rather drain the pancreatic leak, that may cause a greater leak in the anastomoses, or in urinary tract type of injuries. I'd rather leave a drain around those. Because urine with its urokinase will also cause disruption of anastomoses, as we all know. And so in those cases, I will, but I tend not to leave a drain in the other ones. I have other partners who, will swear the other way, but that's when our last discussion, I brought up all these cases because they had never heard about it. And I thought it was worth a discussion here. Thinking back, this was a big defect. What I encountered intraoperatively on take back to this patient for this patient. I don't know what I'll do the next time, as you'll see. Maybe it was worth leaving a drain, maybe, but like I said before, I just didn't want something laying near my anastomoses that's hard and causes inflammation, which is the theory behind drains causing bowel breakdown, anastomotic breakdown.
Gotcha, sir. Thank you. Thanks, everyone. Wonderful discussion. So we'll move on here. So we went through our post-operative imaging, take back. And then, as was alluded to by Dr. Ginsberg, we performed a washout of the right retroperitoneum, 2 small bowel anastomoses, and an ileocolonic anastomosis, and closed the fascia, leaving the skin open for damp to dry dressing upstairs in the ICU. So we'll go through what happened in the post-operative phase. He was eventually extubated, still in the ICU, continued on post-operative Zosyn with the right lower extremity intraction. He did have a brief post-operative ileus. NG tube was kept in place. We started TPN relatively early for him. And then on hospital day 5, we did note a leukocytosis and some cellulitis over the right lower quadrant incision, and a CAT scan that we'll go through here now.
I'd like to make a comment here. Since I wasn't there during that first operation, what I encountered, there was no fascia. So I don't know if you really closed fascia and skin, because otherwise, I'm still very conservative with cases where when there's contamination with colon contamination, I don't like closing skin. And in this case, I think you had no choice because there was no deep. What I encountered when I went back one more time on this case later on when rotating, but I didn't find much fascia there. It was just destroyed tissue, no iliac. There wasn't really something to sew fascial-wise. And I have a feeling that's the real reason you closed the whole skin, was to get the whole thing covered and risk infection, the 40%, 50% infection rate from closing skin completely with contaminated field.
Are you referencing the right lower quadrant wound, Dr. Ginsburg, the traumatic hernia?
Yes.
Yes, sir. So at this point, we're 5 days out with the leukocytosis and cellulitis, and a scan that shows a pocket of fluid here in this space, this right retroperitoneal space. So let's talk about management strategies here at this point. 5 days from the injury. This was, I think, 3 days from the definitive closure. Dr. Untrack?
Yeah, so need to open the skin, let the pus out, and then can you show the cut through showing the retroperitoneal fluid?
Yes, sir. And I should be more specific with referring to this as this was essentially in full communication with the peritoneal cavity based on what we saw in the OR. This was all opened, psoas, iliac fracture, all within the peritoneal space now at this point. It was all widely communicating.
Right, so yeah, so I guess right there where you have, it looks like gas bubbles in a fluid collection. Am I seeing that correctly, or that looks like it's not intravisceral? It's not in the bowel. There you go, right there. Yeah, and that cut. Yeah, so if you open the skin of the right lower quadrant, it looks like you'd be able to that it would communicate with that cavity, and you can either at the bedside or just take them back to the OR and just evacuate that cavity thoroughly and leave a drain in that. I would leave that well drained with a sump or Penrose drain. If I'm looking at the correct area, it looks like just medial to that free fragment of the iliac crest that you're showing in that slide right there, where the looks like fluid with gas bubbles in the
Yes.
fluid extending around the fragment of bone. That seems to be what the problem is. Am I correct?
Yes, sir.
Yeah. So I open the skin. You should be able to, explore with your finger right down into that cavity and evacuate it. You can take it back to the OR to do that, and I think that'd be pretty straightforward. You get that evacuated, let them effervesce, and watch the observe for resolution of the leukocytosis. But I would get on top of that quickly because it's in the area of the fractures. You have an infected, basically infected open fractures.
Mm-hmm. Thank you, Dr. Untrack. Great comments. Dr. O'Connell, any comments?
I'm right there with Dr. Utrecht. I think the questions are, do you do this at the bedside in the OR? And the CAT scan kind of looks to me like it's super deep, communicates with the bone. So I would also favor going to the OR with this, just based on that CAT scan. I would verily, for any resident, I would caution to never close the skin in these contaminated cases. You know, the hospitals are, you may not be aware, but the hospitals are tracking these infections very closely. You will get dinged. So I don't really see the point in closing the skin on these kinds of things. It's just too risky for the patient and for yourself. And then it doesn't seem like ortho is really, you've heard much from them, but like, I don't know what to tell you guys. As I understand bones, when there's a bone that's a fragment that doesn't, you know, is not continuous with other bone anymore, that bone's dead. Okay. It's, this guy is going to have an osteo, in my opinion, or at least that's what I would be worried about. He's probably going to need to get set up for long-term antibiotics. And, you know, these bone fragments might be a nidus there. And I would be concerned that, this guy could have a raging osteo if it's not aggressively debrided. But again, you can't do much but ask the orthopods to evaluate the patient. That's all.
Thank you, Dr. O'Connell. Great comments. Dr. Kasim, any comments?
I think Dr. O'Connell made a very good point there. If you have dead bones there, you know, fragments of dead bones, that is a problem. You know, you shouldn't leave them behind. I would take this patient to the operating room, do a thorough cleanup, remove all the fragments of bones in this area. I also see something metallic there. I wonder if there is some residual bullet fragments lying there too. And this particular patient deserves an extensive, thorough lavage of this area, and then deploy a type of sump drain where you put the suction drain into a Penrose drain and make one for yourself, and a couple of them in this area, so that you can establish effective drainage and continue with the antibiotic and do some prayer to it. Thank you.
Thank you, Dr. Kasim. Dr. Neiman, any comments?
I agree with everyone. This needs to be opened and drained, washed as well as possible.
So we'll move on here to what we ended up doing initially, was placing a console to IR to get a drain into this collection. So this was widely communicating with the peritoneal cavity. So an exploration, as you alluded to, Dr. Untracked, and through the right lower quadrant would have, you know, we would have been in the peritoneal cavity just from the right side instead of through the midline. And so that was the dilemma here: is can we get effective source control with drainage, or would it have been a more, you know, aggressive upfront debridement? And I think that's a good discussion for us to continue having together. Now, orthopedics was involved, and he went to the OR with orthopedics for a right hip incision and debridement. And this case, when we discussed with our orthopedic colleagues what they found, this is through the right lower quadrant incision, which was widened, allowing them to access this purulent cavity and drain it from below. They did perform an extensive debridement of necrotic psoas muscle and noted that this entire space communicated from the pelvic intertable to the peritoneal cavity, with now our orthopedic colleagues encountering a loop of valve within their pocket of irrigation and drainage. So our orthopedic colleague placed a white sponge above to act as a buttress to protect the bowel, placed antibiotic beads, and then temporarily closed over some packing until we can get back in the operating room together for a planned conjoined take back, which Dr. Ginsberg and I did the following day, I think 1 to 2 days later. So now we have this to kind of illustrate the communication. This was the psoas and everything just completely obliterated. And as they performed their femoral I&D, Dr. Untrack, we kind of talked about the communicating wound. In this case, it was really anterior. It was from this traumatic hernia here, but then there was also a ballistic injury to the femoral head and intratrochanteric and all the fractures we demonstrated before. This was a widely communicating space altogether. So when orthopedics approached the field from here, and we joined them to take a look, we were essentially looking up at a loop of bowel that was here, a long shattered iliac crest with antibiotic beads here and a white sponge up here that we removed. So faced with this, we're in the OR with our orthopedic colleagues staring at a loop of bowel and what's clearly an ongoing active infective field, discussing our strategy, our management strategy, particularly with this exposed loop of bowel, which I should mention was viable and with no other concerns other than just being in the field of interest at the time. And so we'll run back to the panelists to discuss what we would do with this case. Dr. Untracked.
Yeah. So in this case, so you did not reopen the laparotomy incision, but you did open the right lower quadrant incision. Is that correct?
Yes.
Yeah. Okay. And then the orthopedist made an incision the lateral upper thigh to expose the hip, and and they were able to look into the peritoneal cavity. Well, in this case, they need to do their debridement, whatever they're going to do. I don't know if I imagine that they wouldn't do any major reconstruction at this stage, but just to debride the necrotic bone, irrigate, and get control of the infection. And then what I would do to keep the bowel out of the wound, I would consider, taking, for example, a flap of omentum, bringing that down over from the inside of the abdomen to cover that space, and basically exteriorize the wound so it was no longer continuous. The wound around the hip and the pelvic sidewall is no longer continuous with the peritoneal cavity. I would consider something like that. Let the infection resolve. Let it start let the wound start to granulate toward the outside, and then the orthopedist would do whatever they're going to do. And at some point, you may need to do a reconstruction of that part of the abdominal wall. If he forms a hernia, after months later, you might need to sew in a sheet of mesh or something to reconstruct the defect, but not now. At this point, I would just try to separate the bowel from the wound and treat the wound open from the outside if you could, to let it close.
It's a great suggestion with the omental flap coverage. I think frequently that's not considered, but obviously a very good option in terms of bailout and coverage in these cases. So great suggestion. Dr. O'Connell, any comments?
I agree with Dr. Utrecht. I think you want to exclude this peritoneal defect. I've seen some early traumatic retroperitoneal hernias actually incarcerate and obstruct, which is just going to make the whole situation worse. I like the omentum idea. It's very creative. It's going to have probably the lowest risk of infection. I was thinking more along the lines of maybe sewing in like a vicryl mesh, like something that's rapidly absorbable. I think a pitfall would be to put a synthetic or permanent or artificial mesh in the setting of infection. That would be a mistake. So maybe a vicryl mesh. I don't know what the other panelists think. Go ahead.
Thank you, Dr. O'Connell. Great points. Dr. Kasim?
This is going to be a very long-term ordeal. And Dr. Kaufman is an expert in something like this. She has shown us how to treat complicated infection like this in some other presentations before. I think you have to use your medical ingenuity as well as your patience, and then apply every trick that you have learned and to salvage this case. It's not going to be easy. It's going to be very, very hard and very long. And everything Dr. Untrash said is true. Thank you.
Thank you, Dr. Kasim. Dr. Neiman, any comments?
It's very challenging. I'm not sure I have a great idea. I'm not sure I have a great idea. If you can close the peritoneum from the hip, then maybe you can exclude the bowel and use a mesh, but it's very difficult. A vicryl mesh sounds like a temporary solution that could work, although I can't really imagine the defect and whether it's even possible to put in a vicryl mesh. But of all possibilities, I think that's what I would try and do. Very challenging.
Thank you. Great comments from all the panelists. Dr. Ginsburg, any comments at this point?
Well, what we saw, what Bobby and I saw, was basically socked in loop of bowel, just about, I would say about 5 inches, 4 to 5 inches. There was no peritoneum. There was just a big old hole with this bowel sticking in there and chunks of bone. When we went in with the orthopods that day, my concern at that time was to protect the bowel, and there was nothing really. There was no compartmentalization of retroperitoneum and that pelvic area from the peritoneum. So I decided to take a piece of vicryl mesh, as discussed by several of the experts on the panel, and I sewed it superiorly to whatever I could sew it to, tissue that was sort of some fascia and even some, subcutaneous tissue skin, protecting the bowel and draping it down and trying to get it underneath the bowel. There was nothing to sew to inferiorly because all there was a hole. There was no fascia, so I didn't attempt to start trying to put sutures there, and it was still infected when we went in there, and I didn't want to loculate any more infection, so I just left it that with and hoping that then that would granulate in once infection was controlled, or wait and maybe swing a piece of flap in there. But then we basically sent this guy, Dr. Liran Barda was the original surgeon on this case, and she had called me, or I can't remember exactly how it went, but we talked to our plastic surgeons. I was thinking, well, once this is cleaned up, maybe swing a flap in there, fasciolata, or a what's it called, a sartorius flap to cover that area and protect everything. And so he was sent up to the Ryder, Maine, as requested by the orthopods and by us. And then at that point, Dr. Barda and Dr. Namayas ended up with back with, after discussions with me as to what to do with this case.
Thank you, Dr. Ginsburg. And yeah, you can see here situated the vicryl mesh is kind of a buttress here. And one of the great points you brought up with me in the OR was really the planes and being very suspicious that any of this on the superior aspect could be bowel, which is why we're extremely superficial with our tacking sutures here. And it did eventually granulate in, did have, as you can anticipate, a prolonged hospital course with continued antibiotics, daily wound care. And then, as Dr. Ginsburg mentioned, the trip back with Dr. Namaya to the operating room where they did have a look, removed the vicryl mesh, did not see any bowel, and performed a primary closure, allowing orthopedics to finally perform their fixation, hospitalized from February 11th to 3/21. I wish I could close on a happy note, but I was looking up his information. I did see he came back to the hospital a couple of days ago with another infection problem. So as the panelists have alluded, a long very difficult, arduous case with a lot of different, pitfalls at really every step. So I think that closes out the hour. I'll allow for any closing comments from the panelists, and then we'll go ahead and wrap up the case. Dr. Untrack.
Yeah, well, I think still, it was a difficult case, and you did an admirable job. You had that infection. Could you have avoided it? We didn't see how the wound looked initially, but maybe initially, it's something for discussion. Packing it open, maybe leaving a wound vac there. I don't know if that would have made a difference, but because we didn't see how the wound looked initially, but that would be the only thing for discussion. What could you have done differently with that hernia in the right lower quadrant? But even so, I think you watched them closely. You got on top of all the problems, and he still he should have a good outcome after resolution of all these little problems that crop up. So I think it's still a good job.
Thank you, Dr. Untrack. Dr. O'Connell, any closing comments?
Some of the things that I found kind of surprising about this case is just the amount of damage that was done by what I presume was, in a civilian context, probably like a pistol caliber kind of bullet. So you're talking about low velocities, low energies, and I suspect when that bullet fragmented, as it seems, it increases the wounding capability of that ballistic much more than sometimes you can expect. Other things, just we don't see them too often, but I believe the literature says that an open pelvic fracture, and I don't mean open book, I mean an open fracture, the mortality of for a pelvic injury, pelvic fracture can be as high as 50%. They're very poor outcomes. You have to be very aggressive and stay on top of the patients to make sure they do well. And then lastly, I'll just say, maybe not in this context, but in these complex pelvic, more like a blunt injury. I personally have seen IR go in and do bilateral angioembolization of the internal iliacs, and I had very, very poor results. These wounds will never heal. They're just not the vascular supply. So maybe not in this context, but I'm just putting it out there. If you ever have a patient that IR wants to do that, I would lobby very strongly against that. Thank you.
Thank you, Dr. O'Connell. Dr. Kasim, any closing comments? Dr. Neiman, any closing comments?
I think it's a great case, and you mentioned it well. Sorry.
Sorry, Dr. Kasim, go ahead.
Well, it just goes to show how devastating gun violence is in our country. If only the politicians could see this. A life lost to injury like this is horrible. It can be preventable. But you, as surgeon and working with multiple experts in your hospital, you've done a remarkable job to keep this man alive, and maybe you might be able to get through this infection in the long run. Who knows? I'm at awe to see how methodical that you have been in treating this patient and deploying all the experts in your hospital, including the professor involved. And it's a good case for me to learn from you guys. Thank you.
Thank you, everyone. I know as we kind of wrap out the hour and running overtime, I'll just take a quick minute to look at, this is what I found is a older study, 2011 out of Temple, 5-year retrospective review of adult patients. Management of gunshot pelvic fractures with bowel injury. Is fracture debridement necessary? They took a population of low velocity gunshot pelvic fractures, ended up with 84 patients, 59% of which had a perforated viscous, 31 small bowel, 31 large bowel, and 30 small bowel. 20% had intra-articular fractures, and their guidelines were performing orthopedic debridement only in cases of intra-articular fractures with retained ballistics, which accounted for 7 cases of their overall population. They only had a deep space infection in a single case. That patient had a missile injury to the hip joint, which was the ballistic was unable to be recovered on the initial debridement, but they did say that it was removed on a second trip to the OR. So relatively low number of infectious complications in this cohort. Again, is a retrospective review. And they have one CT cross section that's pretty similar to the patient that we had. Obviously, this is isolated iliac wing, considered extra articular, but in our particular case, we had intra-articular to the right femur as well as iliac fracture. So I think different beast, I would say, but their conclusions dictate that orthopedic debridement of extra-articular pelvic fractures resulting from low-velocity gunshot injuries is not required, even in cases of spillage. From our standpoint, exploratory laparotomy with intestinal repair and washout with antibiotics is sufficient for extra-articular fractures. Their conclusion does state that retained intra-articular hip joint bullet fragments do increase the risk of infection, and they cited several studies in their paper recommending arthrotomy and debridement in these cases. And as Dr. Kasim astutely mentioned, gun violence awareness, this was a push and a big kind of movement that's been more vocal from all the trauma organizations, and I hope that ours is included, from injury prevention efforts to community outreach to prevent recidivism, stopping the bleed, first responder and bystander trainings. It really does impact so many different areas of trauma care. And so with that, I wanted to thank Dr. Barta, Dr. Ginsberg, Dr. Narvaez, and my outstanding co-fellows, Dr. Gutierrez and Dr. Yerxa, for helping take care of this patient. Thank you to all the panelists for joining. It's a wonderful discussion, what we love about this conference. I think Dr. Martos is still on. Any closing comments, sir? Otherwise, we'll wrap it up there. All right. Thank you, everyone, very much for joining. Appreciate the discussion.